the thing about that warning bleed is that it typically comes early, and it's a great warning sign. Mm-hmm. And if everyone paid attention to it, we'd probably catch a number of things earlier, and people would be more in the realm of curability. The problem that we have is that, when you dig down in the history, because, the old adage from medical school is that it's all in the history, it's all in the history. You've got to examine the patient. You can, get all the fancy tests, but still so much comes from talking to the patient and really working through the history with her.
Welcome to Breast Intentions, the podcast where we take off the bra of expectations and dive into honest, empowering conversations. We're your hosts, Nadine and Cynthia, two Canadian girls who swapped snow boots for flip-flops in the Cayman Islands. This is your space to feel seen, supported, and a little less alone. So grab a cup of coffee or a glass of champagne and get ready for your weekly handful of truth, wellness, and empowerment. Welcome back to Breast Intentions. Today, we're joined by Dr. Troy Gatcliffe to talk about the gynecologic cancers and warning signs too many women in midlife overlook or dismiss as just menopause. From ovarian cancer and hormone therapy to screening, prevention, and self-advocacy, this episode is filled with life-changing information every woman needs to hear.
So on today's episode, we have Dr. Troy Gatcliffe. Welcome to the show.
Thank you for having me.
Thanks for coming. And you are a gynecologic oncologist.
Yes.
What is that?
So a gynecologic oncologist is a comprehensive women's cancer surgeon.
Okay.
We consider ourselves the expert in women's reproductive cancers. So we perform both the surgeries required and administer and order the chemotherapy for those cancers. So women's reproductive tract cancers, starting from the outside, going in, vulvar, vaginal, cervical, uterine, ovarian, fallopian tube cancers. And then there's one other little one that gets grouped with us, which is primary peritoneal cancer, because the lining of your abdomen, which is called the peritoneum, originates embryologically from the same place as your ovaries and fallopian tubes. So cancers that grow from the peritoneum are very similar and have the same characteristics as ovarian and fallopian tube cancers. So we treat primary peritoneal as well. So
very different than a gynecologist, or not very different.
Right. No, not very different. So we all start training as obstetricians and gynecologists.
Okay, so that's what you started as?
Yeah. So I went to medical school and then chose to do OBGYN, and did a residency in OBGYN, and then figured out during my residency that I really enjoyed surgery more than obstetrics. And so that takes you down the path of the various surgical subspecialties in OBGYN. And then I did an elective during my residency in gynecologic oncology, where I went to a different institution and really got my fingers into what gynecologic oncology was, and I was like, yeah, this could sustain me for my life. This could keep me interested for a career. Yeah, I liked cancer. I liked the struggle that cancer patients go through, and I felt that I had never met cancer patients like that before in my career, and these women were like heroes to me, Oh. So I was very drawn to that. And I was also very drawn to this unique place that GYN oncology or gynecologic oncology has in the cancer world, because we are the only surgical oncologists that also give our own chemotherapy. So it's a little bit of a niche specialty in that regard. Other surgical oncologists, like the person that's going to perform your colon cancer or your breast cancer, they're going to have to send that patient on to a medical oncologist should that patient require additional treatment, whereas we don't have to. So gynecologic oncologists, how come?
Like, yeah.
It's a good question. I kind of actually know the answer. So the specialty was really incepted and formalized in the late 60s. And my prior mentor was one of the guys that was around when that was being done. And so I was actually his last fellow. I graduated in 2010 from fellowship. And, he said that when they were sitting down and trying to figure out how to create the specialty, because it obviously needed to be done, GYN cancers needed to have their own world and their own subspecialists and their own surgeons. He said, it would be very wise for us at this point to co-opt the chemotherapy of our cancers into the specialty. And none of the other surgical specialties had done that for cancers. So it was a bit of a struggle. The medical oncologists, who are typically the folks that give chemotherapy, were not too happy with that, but they managed to do it.
Okay.
And so we are the only surgical oncologists that are also trained to give chemotherapy.
So then you also follow your patients through their whole journey.
Yeah, which is great.
The whole arc of their, so
must be so rewarding.
The whole arc of their treatment, and there's hopefully long surveillance and into full remission and cure. Yeah.
Wow. Very cool.
That is cool.
Yeah. So let me start with the first question that I have for you is, for women in midlife, what are the most common gynecologic cancers that you're seeing right now? And are those trends changing?
Yeah, that's a great question. So most of the gynecologic cancers cluster around the postmenopause, but there is an increasing trend in the last, I would say, decade, that we are seeing an uptick in endometrial cancers. So that's cancer of the lining of the womb. Okay. And that's heavily related to the epidemic of obesity, along with a couple other factors. It's not just that, but endometrial cancer is one of the few cancers that continues to rise. And we are really trying to study and figure out why that is happening. And one of the putative causes is the fact that the world's getting heavier. The population's getting heavier, and we see more and more obesity. It is very much a lifestyle cancer.
Okay.
Yeah. So
is it?
It is.
Okay.
Yeah. Endometrial cancer, most of it, not all.
Okay.
Yeah. There's exceptions to everything, but
okay.
Yeah.
And before it used to be women postmenopause.
Yeah, it was postmenopausal women, postmenopausal.
Still probably is.
Yeah, it still is. It still is mostly preponderant in the postmenopausal group, but we're seeing younger and younger women with endometrial cancers. Yeah.
Okay. So then for women who are older that have the cancer, is that also like lifestyle related, or is it age related? Or
it's lifestyle.
It is
lifestyle. A lot of lifestyle relatedness. Yeah.
I might have to get into a couple of those questions too.
Yeah.
What are the symptoms that are often dismissed as just menopause that could actually be something more serious? And I think we were just talking about it before, which is the bleeding as well, right?
Yeah, that's the thing, is that folks, will sometimes think, well, they just had a bleed and it was just a period. But, we really try to educate our patients, especially the general OBGYNs, that the textbook definition, the medical definition of menopause is the absence of menses for a year, right? I think most people know that, but people kind of forget that. So, a year and a half goes by and you have a bleed. That's not normal. That's a postmenopausal bleed. And that needs to be investigated. It doesn't mean you have cancer.
Right.
But it does mean that you need to follow up with a physician, check the thickness of the lining, probably have a biopsy, and figure out what's going on.
So don't just chalk it up to
Oh, just a random bleed.
Yeah, just a
Yeah.
random bleed.
Yeah.
Yeah, if you're still in that perimenopausal time where your periods are becoming irregular and
Yeah.
it's been a few months and you're having on and off periods and, but, the joke that I always say to my patients is that, your last period doesn't come with a flag, I'm your
Yeah.
last period.
Right. Yeah.
You only know that in hindsight.
Yeah.
True.
But once you pass that 1 year mark, and people forget, life is busy.
Oh,
and
yeah.
they're like, well, what was my last period? February or
Right.
last
Yeah.
February or
Right.
last April? But women are pretty in tuned with their bodies in
Yeah.
a way that most men aren't.
Yeah.
And I want to ask this because I think that there might be other people that may want to ask it as well. Is like, what do you consider like the bleed? Like, is it,
It could be
like a
that's
spotting,
great,
or
yeah.
is it
So I
something
actually
that's-
gave a talk in the HSAs. They had the women's conference.
We were there.
Yeah.
Yeah.
And I talked about postmenopausal bleeding, and it can be anything. So
Okay.
it doesn't have to be like a bright red bleed. It doesn't have to be a period quantity bleed.
Okay.
Any postmenopausal woman that sees blood-like or even pink staining on a pad or a panty shield or a liner or anything or on toilet tissue, that's not normal.
Okay.
It just means like you need to check it out.
Yeah.
Don't dismiss it.
Okay.
Far less like a real bleed.
Okay.
Yeah.
Okay. And are there any other symptoms or?
Of endometrial, are we talking about specifically or?
We could, I guess. Yeah. If that's maybe more of the common one that you see, I guess.
Well, that's the one that we're seeing rising.
Okay.
So that's the one that kind of we're focused on a lot.
And the bleeding would be related to the endometrial? Mm-hmm. Okay.
Yeah. But, the other cancers can also, specifically cervical cancer, can cause bleeding. Ovarian cancer, not so much, but vaginal cancer is very rare cancer, super rare. Even for us, we see it very, very rarely. Vulvar cancer. But bleeding on the whole in the postmenopause needs to be looked at,
Okay.
needs to be investigated.
Okay.
I think that's really good. I'm glad that you said that because I think
Yeah.
I probably would just be like, oh,
Like
being a
maybe
woman,
it's- Yeah.
it
yeah.
sucks. And I probably would kind of chalk it up or just ignore it and
Yeah.
go about my day.
Yeah,
Even a year into it or a year and a half into it.
sure.
Yeah.
Yeah.
So that's good.
Yeah. I do actually have an old client who it happened to her. And she did go and see a doctor. We're both from Canada. And where I think a lot of people also are like, I'm not going to bother going in to see the doctor. One, I probably can't get in to see the doctor. It's going to be a long wait. And then possibly getting dismissed or something like that. And she worked for a hospital actually, and she ended up going in and she did have cancer. So, and,
Endometrial.
I don't know exactly what it was, but I'll have to ask her now that we're talking about this.
Now that we know a bit more. Yeah.
If a woman could remember only one red flag symptom, what would you want it to be? I'm going to guess it's probably the bleeding.
Yeah,
Bleeding.
it's the one we're talking about. Yeah, it really is. Because, the thing about that warning bleed is that it typically comes early, and it's a great warning sign. And if everyone paid attention to it, we'd probably catch a number of things earlier, and people would be more in the realm of curability. The problem that we have is that, when you dig down in the history, because, the old adage from medical school is that it's all in the history, it's all in the history. You got to examine the patient. You can, get all the fancy tests, but still so much comes from talking to the patient and really working through the history with her.
Like history of family or
No,
history
the history of the complaint.
Oh, okay.
So, you're talking to the patient and she's like, I've been having this bleeding. Okay, well, tell me about this bleeding. How long have you been having it? How heavy it is? When do you remember that it first began? She's like, and, they sometimes have a partner or a husband or a daughter in the room. And they're like, I think it was like 6 months ago. I was like, well, 6 months ago, it was summer. let's talk about last Christmas or last New Year. Try to peg it to different times in the calendar. And she'd be like, yeah, I was bleeding at Christmas. I said, well, that's a year ago,
Right.
And then sometimes patients will be very honest and be like, no, this happened once or twice 2 years ago, and I never followed up. So then you're like, oh, so now you have someone who's had on and off bleeding for a number of years. And then the possibility that I'm not saying that they would, but the likelihood that they may have more advanced disease becomes really real.
Yeah.
As opposed to the patient who, has a bleed and says, oh, this isn't
Let me
real.
check that
This
out.
is not
Yeah.
good. I'm going to call my doctor, and is in a month, gets a biopsy in a month, gets a diagnosis, gets a surgery.
Right.
Much higher likelihood that she's going to be caught early.
Okay.
That's true for all cancer, I suppose, right? Is the earlier detection, the better
Yeah.
outcome.
100%.
Most of the
100%. Yeah. I know that I looked further down in your questions and you were talking about the problem with some of our cancers is they don't have, and that's the thing about the red flag warning sign, the bleed, it's there, it's real. We're not so lucky with like ovarian cancer, very silent, very vague symptoms. Not often, it doesn't have a primary red flag warning sign that people can pay attention
okay.
to.
Right.
I
Yeah.
believe that's what Cass had, was ovarian.
I think that's where it started, right?
Yeah. Yeah. Is there some symptoms where it's like stomach issues, like weird bloating, like
Right.
lower abdominal?
Yeah, that's
bloating?
ovarian.
Okay.
Yeah, that's ovarian. Or it could be a symptom of any of the advanced gynecologic cancers, but that's kind of one of the main ones for ovarian. Yeah,
It could probably also be colon too, right?
100%.
Yeah.
Yeah.
Could also be just being a woman and having, I don't know, like lots of.
That's
this
the
is
thing.
It's like,
That's the thing is that
I had a crappy meal last night. I feel
exactly
bloated.
Yeah.
women are, you see, women are so used to the course of their life to understanding bloating symptoms, right? And where does bloating come from, right? Bloating comes from the fact that when you menstruate every month, a certain fraction of your menses ends up in your abdomen. This is not a fact that's actually known by a lot of people. But when you,
What?
yeah, it doesn't all go out your cervix. It doesn't all go out your cervix, out your vagina, and into the world, right? Onto a pad or into a tampon. So there are 3 exit points from your uterus, the 2 fallopian tubes and your cervix. Now the cervix is the bigger highway. And so most of your menses most of your menstrual flow comes out of your cervix and into the vagina and out. But a pretty decent portion ends up going retrograde through the fallopian tubes. It'll follow the same path as a sperm. Okay. And it'll spill out the fallopian tube into the abdomen. And your abdomen is not a place that likes blood.
No.
So when blood hits your abdominal lining, the peritoneal lining, you get bloated and you get gassy and you feel crampy and you feel yucky and your GI tract goes off and you going to the bathroom doesn't feel great, and all of those symptoms that men have no concept of. None, because but women get that, 9, 10, 12 times in a year, so they're very used to it. So you have that built into your memory, your genetics almost. So
Yeah.
you take a 60-year-old woman and she's just like, oh, I just kind of feel gassy and bloated.
Yeah.
Like I had a bad taco.
Yeah.
I don't know,
Exactly. Yeah.
But those are some of the very whispering signs, as we say, of ovarian cancer.
Oh, wow.
Yeah.
Wow. Okay.
Okay.
It was like
I don't know what I thought, but I really did not know that.
No.
I did not know that. I think I just thought like everything was inflamed and
That's what I thought.
Everything is inflamed too,
Swollen
but
and
it has a
sore.
lot to do with retrograde menstruation. So
wow.
when we do surgeries on women for other things, young women for like a fibroid or a cyst, and they happen to be on their menses, and we put a camera inside their belly,
You can see it.
find a pool of blood.
What?
Yeah.
Oh,
You'll-
this is so crazy.
Where does it go?
Yeah.
That's absorbed.
It does.
Just
Yeah,
back
it just
into
gets
the-
absorbed. It doesn't get, the blood breaks down.
Like it doesn't come out in your
Yeah.
stool and all of a sudden
No.
you see
No.
blood.
No,
Right.
no,
Okay.
yeah. The blood will break down, decompose, and it'll get absorbed by the lining of your abdomen. Yeah.
Okay.
Wow.
Mm-hmm.
It's wild.
It is. It's very interesting.
We should change the podcast to wild gynecology facts.
We could probably do a
We could probably do a
whole.
whole episode on that.
Yeah.
Yeah. Wow. No, that's
Okay.
I'm way
Huh.
too old to just be learning that.
Yeah. Okay. Oh, okay. So this is a question that I do want to ask because I think that a lot of people would want to know as well is women who are in their 40s and 50s, what should they actually be prioritizing when it comes to screenings? I'm guessing their pap smears, which aren't even like yearly anymore. Right?
Yeah.
Like, what's your thoughts on that?
So I think from an epidemiological standpoint and from a population perspective, I get where the task forces that look at these guidelines and create them, I get where they're coming from. And I think that the guidelines are built around women who follow up and women who are really health literate and have good access to healthcare.
Okay.
The problem is that not everybody has good access to healthcare. Not everybody has really high health literacy, and not everybody follows up. So even people who are, highly educated and have great insurance and have phenomenal access to care, sometimes don't follow up.
Yeah.
And, life is busy. As I've learned, taking care of women for my life, women are the primary caregivers of every family, including the husband. So they're taking care of everybody and often not taking care of themselves. This is something that we know really well, So there's sometimes some self-neglect and, 2-3 years have gone by and somebody hasn't gotten a pap smear. Now, if you're in a mutually monogamous relationship, you have a long history of normal pap smears, you have no concerns for any high-risk behaviors, and that could be a whole podcast.
High risk behaviors. What do you mean by that?
High-risk behaviors. So high-risk behaviors for cervical cancer, for pap smears, are the fact that you are in a mutually monogamous relationship. So you don't have any other partners and your partner doesn't have any other partners. So as soon as there is a thought that that may not be the case, you now have a high risk situation.
Oh, okay.
So that person is now exposed potentially to HPV in a way that she was not expecting
Okay.
or knowing. And, men have affairs, but women have affairs too. And so, I always say to my patients, I said, do you feel like you're in a mutually monogamous relationship? And if the patient says, yes, I feel secure and comfortable with that. You have a long history of pap smears. Okay, great. I'll see you in 3 years for a pap smear.
Okay.
But, if that's not the case or something's happened or there's been a question of infidelity or the patient herself has had an outside infidelity to whatever relationship, or even if there's no infidelity, she just has
Multiple partners. Like it could be
multiple
somebody who's
partners.
Like a single
single
person.
and
Yeah.
somebody who's single and dating,
yeah.
then that person needs to be followed more closely,
That's good to know.
Yeah. So with the advent of HPV testing, where we're headed is that HPV testing is going to become the mainstay. It already is, but the world is transitioning to that, where the presence of the virus is more predictive of what may happen with that individual patient than the actual smear itself.
And that one's also silent too, right?
Yeah, cervix cancer can be kind of silent in the very early stages when it is treatable with surgery, which is really only in the very early stages.
Okay.
It can be quite silent.
Okay.
So, like, you know, for example, I tell older women, older patients, you know, sometimes spouses pass, or people get divorced or separated, people date anew. Then to me, that woman is like an 18-year-old,
Yeah.
even if she's 68.
Right.
Because now she's kind of back in the exposure realm where she could be being exposed to the virus again. You know, maybe after a long life of monogamy, for whatever reason, that relationship has come to an end, and now she's found a new partner,
Right.
or has a new love. And now that's a different level of exposure.
Okay. Oh, that's actually one of my other questions is about pap smears. So then are pap smears enough, or do they miss certain cancers that women assume they're protected from?
Yeah, so that's a great question. So I think women think that like a pap smear is a global cancer screen,
Yeah.
and it's only a screen for cervix cancer.
I didn't know that either.
No.
Yeah.
Did you know that?
Only a
No.
screen for cervix cancer. So a pap smear, as it is now, collects cells from the outside of the cervix. And it's one of medicine's most revered screening tests. It's been around for decades.
Yeah.
And it's highly effective. It's really easy to do. It's low cost. It's the perfect screening test, except for the fact that, you know, you have to come into a doctor's office and, you know, put yourself in stirrups and have a speculum placed in your vagina. But not even so now, because now that we have HPV, you can self-collect in the privacy of your home.
Really?
Yeah, you can self-collect your specimen, especially the HPV specimen. But back to the pap smear. The pap smear and the whole HPV thing is really just for cervix. It's not for ovarian. It's not for fallopian tube. It's not for uterine cancer. It's not designed to be a screening test. So it's not a global gynecologic screening test. So I think women think, you know, I've gone
Yeah.
for my pap, I'm good.
Yep.
Oh,
So-
yeah.
Sure.
So
Yeah,
women
for
with ovarian cancer all the time will be like, they come in, I had my pap.
Yeah.
I was like, I know you had your pap, and your cervix is perfect.
Yeah, right,
It's
yeah.
great. But
So what can you do? Like, what else can you do?
for what?
Like,
To
let's
screen
say
for the other
screen for like
cancers.
ovarian and
Yeah.
stuff.
So we medicine are working really hard on that. How to come up with an effective, population-based, cost-effective screening test
So then it's
for ovarian. We don't have one yet.
so then is it fair to say that it's kind of left up to the patient to convey how they're feeling or their symptoms to you to
Well, no, because that kind of puts it on the patient, and this is like a thing that we deal with, you know, with ovarian cancer a lot, where patients get into a situation where they get into like self-blame and like, how
Why didn't I catch this sooner? Why didn't I know
Yeah.
something was wrong with me?
Yeah, 70-80% of ovarian cancers are diagnosed at stage 3, advanced,
wow.
like
Yeah.
widely disseminated in the abdomen.
right.
And patients will be like, I don't understand how I got here. I don't understand how I missed this. And I'm like, well, that's you and most women.
Okay.
So it's not like the patient missed it.
Okay.
It's the fact that the cancer is a silent
Right.
whisperer. Yeah. Doesn't have that warning sign like the bleed.
Right.
Yeah.
It's very sad.
It is. It's you know, you hope that there's something that you can be like, well, everybody just do this
Yeah.
and then you'll catch it.
Yeah.
But it's like,
Well, I think
Not
lower
that
down
easy.
we're going to get to some
Okay.
questions about prevention.
Oh, okay, great.
And like we have a whole new drum that we're beating with that. And so we'll get to that, I
Good.
guess, when we get there. When
Okay.
we'll circle back on ovarian
Yeah.
because
Okay.
there's a big new light on the horizon.
Good.
For that. Yeah.
Good. Okay. What about genetics? So, do genetics play a role, and should women consider getting genetic testing or?
Yeah, so I think the time will come really soon where probably we'll all be tested for a lot of genetic things just because the cost will become so low, but we're not there yet. So still we need our genetic counselor colleagues and all of their expertise to help us delineate who are the people to test
Okay.
because we can't just test the whole population.
Right.
Because it would be too expensive.
Right.
And we're not there yet, but we're going to get there.
Okay. Okay.
But the most important thing is obviously family history. So we were talking about history,
Yeah.
the history of the complaint, the history of the symptom, but family history and your genetic history is super important. And, if there is a clustering of cancers in your family, then you want to go to a genetic counselor. Very easy to get referred by any primary care physician. And let a genetic counselor do your family's pedigree. And sometimes, people have cancers in their family, but they're not clustering around genes.
Yeah.
Like you have an uncle with pancreas and a dad who had lung and an aunt who had cervix, for example. Those don't match.
Okay.
But what we do know is that breast and ovarian cluster. So about 25% of the population, around about there, have cancers that are genetically driven in breast and ovary. And now we have more than just the big two, BRCA1 and 2. We have about 8 genes that we know about, and we're discovering more as the years go by that lead to an increased chance of developing breast and ovarian cancer. So if you have a clustering of breast in your family, in particular breast under the age of 50 or premenopausal breast cancer, and ovarian, which tends to cluster in the postmenopausal patients, but you have those clusterings, that family needs a pedigree and they need to be tested. Similarly to endometrial cancers and ovarian cancers cluster along with colon cancers in a syndrome called Lynch syndrome.
Heard of that.
So Lynch syndrome, the two big cancers in Lynch syndrome are colon and endometrial. So
Okay.
a bunch of colon in the family and a couple of endometrials here and there, maybe an ovarian. That family needs a pedigree. They need to be tested. So there are some cancers that cluster in gynecologic cancer. Breast, colon, endometrial, ovary, those are all the ones. The common misconception, for example, is patient will come in and say, my mom had cervical cancer too, so this must be genetic. But of course, like we've been talking about, cervical cancer is caused by a virus that's sexually transmitted.
Right.
So if you have a family member, even a first-degree relative that had cervical cancer, that's just chance. It has
Right.
nothing to do with genes. But you see, patients will see that as maybe a genetic
Yeah.
connection.
Yeah. Oh, okay. Very interesting. Yeah. Let's go over to like proactive steps and different things that women can do to help reduce their cancer risk.
Sure. So
We talked about some of them.
yeah, we
you
talked
know,
about
but-
some of them. So I think screening for cervix, really big, really important. We talked about the relaxed guidelines, but if you're young and you're dating and you have multiple partners in a year, or you're older and you're dating and you have multiple partners in a year, you probably need to continue getting pap smears annually. So screening, really important. The thing that we're moving to with ovarian cancer, which is really huge, and there are some big international studies going on that I think will result in the next few years that'll probably really change the paradigm, is that we now know, not now, for a good while now, number of years, that really and truly most ovarian cancers actually begin in the fallopian tube.
Okay.
So what we've been calling ovarian cancer for generations are actually really fallopian tube cancers. So some really elegant studies over a decade ago realized that there are some precursor lesions that develop in the fallopian tube that then turn into cancer cells that then drop onto the ovary, and we thought that they came from the ovary itself, but they actually come from the tube. The good news is that your tubes don't do anything except help you reproduce. They don't provide support for your pelvis. They don't make hormones. So once you are certain that you have completed childbearing or that you no longer want future fertility, we're now moving really heavily towards what we call opportunistic salpingectomy, meaning that anybody in any surgical specialty ends up in the abdomen of a young woman who has declared, she obviously you have to know that. Mm-hmm. And that's a key thing, because we can't have patients feeling that doctors are just going to go in and whip out their tubes.
Right.
Mm-hmm.
But once the patient has been counseled, and what we're trying to do is get all of our surgical colleagues, general surgeons, colorectal surgeons, not just gynecologists, everybody to buy into the fact that if you have a patient that states that they do not desire future fertility and or has completed childbearing and or has their tubes tied, like a segment of the tube removed, and you're in her abdomen for some other reason, take out the rest of the tubes. So we think that we will have a really significant decrease in ovarian cancer, which is one of our rarer cancers, but one of our cancers that we don't have the screening test for, or a great screening test for, so it's caught often late. We could really have an impact if we remove the fallopian tubes.
You can just remove the tubes without taking the ovary, without...
Yeah,
Oh.
yeah. So, explaining the anatomy to women is, to my patients, is something I do all the time. And, even in clinic this afternoon, I had a patient that had avoided a hysterectomy for years because she thought that her hormones came from her uterus, but they don't, right? So your tubes, your ovaries, and your uterus are very separate organs, and they can be dealt with surgically separately. So having a hysterectomy, removing the uterus because of, say, bleeding or fibroids, doesn't mean that you automatically have to lose your ovaries as well.
Is that considered a partial hysterectomy?
So that's a great word. That's the misconception. So
Okay.
So what doctors call a partial hysterectomy is when the cervix is left behind, which is a part of the uterus. The cervix and the uterus have two different names, but they are kind of one organ, one unit.
Okay.
But patients think that a partial hysterectomy is where the ovaries are left behind.
Yes.
So the medical terms, the medical terms for the surgeons are total versus partial, which is where a piece of the uterus is left behind.
Okay.
Meaning the cervix.
Mm-hmm. Huh.
But hysterectomy is often done with removal of the tubes and or ovaries as well. And that part of the procedure has a totally different name.
Oh.
And it has a totally, it's not hysterectomy.
Right.
So,
Oophorectomy.
It's oophorectomy.
Yes, I had a long
A right
side note.
oophorectomy. Side note.
I had
a right oophorectomy.
Right, and the tube on
And the
that
tube.
side. Yeah.
So you had a right salpingo oophorectomy, and it was done without removing your uterus.
Yeah.
Yeah. So salpingo oophorectomy or salpingectomy or oophorectomy are all different pieces of the puzzle. So you don't have to, you can go into a woman's abdomen, not touch her uterus, say there's nothing wrong with her uterus. Well, you can take her uterus off. Well, nothing's wrong with it.
Yeah.
Classic, let's say 42-year-old woman, 3 kids, no plans for more. she's done. She may even have had her tubes tied, where a small segment of the tube was removed to interrupt the tube. But the rest of the tube, most importantly, the fimbria, which is the end of the tube that sits on the ovary that picks up the egg, that brings the sperm and egg together. That's the part that we really want to take out. So the fimbria can be left behind after somebody's tied their tubes. Say now that 42-year-old woman ends up with an appendicitis and she's in the hospital and she has tubes are tied. Then what we want is to evolve to the point where the general surgeon who's going in to take out her appendix knows in the future that the very best thing to do for this woman is fix her appendix. But while you're there, super simple. Just go chip, chip, take off both of the tubes and get them out the patient, because that could save her from a future ovarian cancer. So opportunistic salpingectomy.
Yeah.
I see.
I can imagine, because it's not something that's happening a lot right now.
No.
I can imagine, though, there's going to have to be so much education around it,
for
because
sure.
a woman's going to be like,
Yeah.
I don't know what you're doing.
Yeah.
And I
Don't
know.
consent to that. Don't take.
I
no,
need
no.
to
my body
learn
parts,
more about it.
Yeah.
And
Yeah. But, you know, I mean, look, we're all patients at some point, and you have to just trust the physician, the surgeon that's taking care of you. And I think, you know, our job is to educate. You know, I tell the med students that I teach every day in Miami that, you know, the word doctor is Latin for teacher. So doctors are teachers. And our goal is to teach our patients about their bodies. And remember that patients, unless they're doctors too, medical doctors don't know.
no.
You know, they don't know. You can't assume that, you know, even the most highly educated patient understands that her tubes don't make hormones, that her uterus doesn't make hormones, that if you take out her uterus, you could leave her ovaries behind. You can't assume these things.
And honestly, like, I don't think we talk about women's bodies, or at
Yeah.
least haven't in the past, like
Yeah.
enough. Like, we're women, we don't even know this.
Yeah.
No.
Like, it's just all like, we just assume it's all connected and nobody tells us
Yeah.
different. Why would we go? We're not going to go research it ourselves unless there was a reason for it, unless we
Right.
were looking something up on
Right.
Google.
Well, it's the reason that, you know, it's the reason that breast is not only is breast the big female cancer, but, you know, breasts are on the outside.
Right.
They can be seen.
Yeah.
They can be examined. Women have a very personal relationship with their breasts because it's part of their outer structures. It's part of their body image. You know, it's part of
Yeah.
who they are. You know, it's like it's your arm or your nose, you know.
Yeah.
Right.
But people don't have a great understanding of what's going on in their
Yeah,
pelvis.
definitely.
Yeah, they don't understand like tubes, ovaries.
Yeah. We know that we as women, like, we know they're there.
Right.
They have a job and they do what they're meant to do. But
Right.
as far as, I'm learning a lot.
Tons of women
today.
ask me, for example, that if they have a hysterectomy, what'll happen to their vagina,
Okay.
right?
Yeah.
Because lots of women have hysterectomies and, you know, obviously want to go on to be continually and normally sexually active.
Right.
And you have to show them diagrams and bring out and say, well, nothing's going to change about your vagina.
Right.
And for intercourse, what you need is your vagina.
Right.
So people say, well, is it going to get shorter? Are you going to close it? Is
Yeah.
it going to
Yeah.
change? And the answer is, with a normal hysterectomy, no, you know?
You wouldn't
So,
even know.
Yeah. Yeah. You wouldn't even know. There'd be no difference.
Right.
Yeah.
Okay.
Okay. It's very interesting. So we're talking about midlife women. We're talking about hormone replacement therapy. A lot of us are taking it or considering taking it. Does HRT increase cancer risk, or is that like misunderstood?
I think it is misunderstood. And the scientific answer is it increases the cancer risk for certain cancers. But that increased risk, even though by multiples sounds a lot. For example, you know, if you said to somebody, you know, that if you take HRT, you would double or triple your rate of endometrial cancer, it sounds like, whoa.
Yeah. Wow.
But the actual statistical number, the true rate of increase, is really small, relatively speaking.
Okay.
So, I was trained by the very same guy that I was talking about that was around when the specialty was being incepted, Philip Desaya. And he was a great believer in hormone replacement therapy for women. Not just back then, because this is only 16 years ago I left fellowship.
Okay.
So people would come from far and wide to get hormone replacement therapy from him. And I think once you counsel people and you educate them on what the risks are, there's a certain cohort of people for whom taking hormones in the postmenopause is really life-changing. Mm-hmm. I think where we are right now is that there are a number of people that are taking hormones because it's just the thing to do.
Right.
And everybody wants to feel better, live longer, and not go through menopause or not have to deal with those symptoms. But I think that what I still counsel my patients to do, and even the female members of my family, is, see how menopause feels to you. And you can tackle various aspects of the symptoms that you have in various ways that may not increase your risk as much. Now, if you're having a terrible, terrible menopause and it's a really, really rough ride and you're very, very symptomatic and you're very miserable, then you're probably a great person to take hormones. Mm-hmm. Of course, provided that you don't have any contraindications to taking hormones, like you're a smoker or you have hormone receptive positive breast cancer or other things that could be really important. Right. But let's just take your average woman who's going to go into menopause at 49, 50, 51. I kind of try to encourage folks to kind of like see what it's going to be like and not just be like, well, I'm perimenopausal, so I'm going to start taking hormones. I'm like, okay, well, that's not unreasonable, but how do you know that it's going to be terrible?
Yeah.
Now, as a man, I'm never going to have the symptoms and I'm never going to understand them. But I've counseled and spoken to so many women who go through menopause that there's just the hugest breadth, just like of humanity. There's just this wide range of experiences. Yeah. And I think that everybody automatically focuses on the kind of like the crazy, sleep deprived, upset, anxious woman who's having terrible hot flashes and has a dry vagina and has no libido and her whole world has gone upside down. Well, that's a lot of people. That is a lot of people. Yeah. 100%. Mm-hmm. But there are a lot of people that don't have that experience as well.
Right. Yep.
That may have some of the symptoms. So what are your symptoms? Yeah. What do you need the HRT for? For example, if your main complaint is vaginal dryness, one of the most common complaints, you don't need to take systemic HRT to take care of that. You could actually take vaginal hormones, right, which don't have the systemic risks. So if someone comes in and says, I have a couple of hot flashes, I'm okay. I don't wake up at night. I'm not like there, with the air conditioner turned down and my husband is like an ice cube and I'm in the bed,
Right.
But, like the dry vagina, doc, it's terrible. Mm-hmm. We have a fix for that. We can tackle that one symptom. We can tackle low libido, on its own, So it depends on what the symptoms are.
Okay. So you did mention how weight gain can influence cancer. How do estrogen levels, let's talk about all of these, I guess, how they can influence cancer, like estrogen levels, weight gain, metabolic health, in midlife specifically. How is it influencing cancer risk?
So I think that a number of cancers are linked to obesity. As we've talked about a lot in the beginning. Endometrial cancer is. Ovarian cancer also is. So having
a higher
having a
weight?
higher BMI leads to increased estrogen levels. Because what happens is that your extra adipose tissue, the extra weight that you're carrying around is adipose tissue. And adipose tissue, as I like to try to explain to my patients, acts like an ovary. So there is peripheral conversion of hormones into estrogen. So in a very obese woman, she has higher levels of endogenous estrogen coming from the extra weight that she's carrying. And for example, the mechanism in endometrial cancer is that the way you don't get endometrial cancer when you're reproductive age is because you have both hormones. You have estrogen and progesterone. And the estrogen causes the lining to build, and the progesterone helps you to slough the lining and get rid of it. And then the whole cycle repeats, every 28 to 35 days.
Yeah.
But if your ovaries have failed and they're no longer producing hormones, you don't have a source of estrogen. You don't have a source of progesterone. But if you're really heavy, you have increased levels of estrogen. So over time, not in the way that it happens in a monthly cycle as it would for a young reproductive age woman, but over years, the lining of your uterus is being stimulated by that estrogen.
Okay.
And the lining is building up, and it's slowly building up over months to years, and you don't have the progesterone to slough it off and get rid of it. And then it stays there, and it builds, and then it transforms. So that's the mechanism for obesity and endometrial cancer.
Right.
So one of the things you can do is just really try your best to have a BMI that's under 30. And we know now that BMI is not the be all and end all. It's not, we don't want to have people just, if they have a BMI of 31, they're failures, they're not, but it's still a good gauge of where you are, weight wise. So you want to try to move down to a more normal weight.
It's a good way of explaining it as well, to people to understand how that link is with weight and
Yes, because I think
estrogen.
I would have assumed, because a lot of times, in health, we talk about having a higher weight, and it's because you're, eating unhealthy foods. And so maybe it's the unhealthy foods
that contribute
to the cancer.
Yeah.
But it's actually the weight itself.
It's actually the adipose tissue itself. In endometrial cancer mechanism, it's the actual weight itself that you're carrying that's creating more estrogen that your body does not need.
Right. Wow. Okay. Are there specific lifestyle habits you consistently see in patients that either increase or decrease risk?
Lifestyle things. So, for example, in cervix, the lack of understanding of the transmission of the HPV virus, the lack of understanding of protecting yourself. I guess when we talk about prevention, I'm a huge advocate for the HPV vaccine.
Okay.
But if you're going to have, sexual contact with a new partner, and this is not someone that you've known terribly long and you don't know their sexual history, because, you don't fall in love with people and say, okay, let me have that sexual history now. Let's talk through, maybe you want to think about barrier methods, not necessarily for contraception.
Yeah.
Although that's what they're for, but they're really for protection against the virus. So, so folks who are careful and use barrier contraception have a lower risk of HPV transmission. That'll cut down their risk of cervical cancer. Folks that maintain, or try to maintain a more normal BMI, or at least can, if they've gained a lot of weight, try to move their BMI back down to, something, under 30 or around 30. Because morbid obesity is defined as a BMI of over 40. And, we see folks in the office every day with a BMI of over 40.
Right. Okay. And 30, like, I think, I don't know this, but say a BMI of 30, that's not like a stick thin person.
Not at all.
It's
not at all.
A average type, like even maybe a little
yeah
on the not skinny side. Like
exactly.
Yeah.
Okay. Exactly. So
like, because I don't want people to think like, oh, I have to be real thin or I have to lose all my weight. It's not like a BMI of 30 is.
It's very reasonable.
Big.
Yeah.
It's not tiny, I guess is what I'm trying to say.
Yeah. I think that, in the Western world, because of the obesity of the epidemic of obesity, we've all become acculturated to seeing heaviness as normal. And it always strikes me when I travel and see different cultures and I'm like, wow, everybody in the Western world's a little on the heavy side.
Yeah.
Because you go to Asia or you go to Europe or you go to other places and you're like, on the whole, people here are a little not so heavy. Yeah. But in the Caribbean, I'm a Caribbean man myself. So in the Caribbean, when I've lost weight in the past, my mother says, what's wrong with you?
Yeah, right.
You can never win.
You
can never win.
What's wrong with you? You don't look well.
Right.
Can I ask you a question about the HPV? They're doing it, you can get the vaccine, is that what it's called? At school.
Yeah.
And so they're doing it at school. My son goes to school and they were giving them there. Is it a one-time?
It's 2 now.
It's 2.
It's
okay.
2. It used to be more, but it's 2 shots.
For life.
Yeah.
You can only do it when up to a certain age.
I was just going to say, like,
no, so
can we do it as adults?
No way.
Yeah.
Oh.
I would give it to anybody. I would give it to anybody that any woman of any age, and we have to vaccinate men and women. It's not a woman vaccine.
Okay.
It's not a woman vaccine. So all of my kids happen to get it in their pediatric vaccination schedule because I believe in it, and it's offered now. And,
right.
But we have a real cultural barrier, and in the current political climate and in the current health climate, there's a lot of vaccine deniers and a lot of that stuff going on, and that can be tough. That can be challenging, and parents are, we're hoping that people will really come around to the fact that, you're going to get your smallpox and your measles, mumps, and your tetanus booster, and when you get to 10 and 12 and you're going to get your first HPV vaccine, because you really want the vaccine, you really want the immunity there before human beings start to become sexually active. But to your point, women come in all the time with cervical dysplasia or the precancerous lesions of cervical cancer, the precursor lesions of cervical cancer. And, we treat them with, removing the cancer with a procedure called a LEEP procedure or a LETS procedure. But, it was caused by one strain. There are 9 strains that the vaccine protects you from. So unless we bother to go through some pretty expensive and not necessary testing, an individual woman's dysplasia would have been caused by one strain, but she's going to have immunity to that strain only. So the vaccine contains 9 strains, and 7 of them are the most common strains for cervical cancer. And you would want protection for the other 7 for the rest of your life too. So even, 28, 35 year-old women, they're all eligible for the vaccine. And in fact, if a woman comes in and she says to me in her sexual history, I'm 42 and I've never had intercourse, but I'm going to get married and I'm going to start having intercourse because that's her belief system and that's where she is, I'll be like, have you got the vaccine? And she's like, no. I was like, you need the vaccine. Yeah. Right. Because,
yes,
this is what it protects you from.
Okay.
Yeah.
That's interesting. I thought that it was only up to a certain age that you could get that and be protected.
Yeah.
So I just want to make sure I have this right. So HPV is caused by sexual not caused by, I shouldn't say that.
Yeah. Transmitted
through sexual intercourse. And that's how you can, not 100%. If you get HPV, do you get cancer?
No, if you
Okay.
if you get HPV, you have you have the cause, but it
Okay.
doesn't mean you will develop it, right?
Okay.
There's a whole bunch of host factors.
Okay.
But HPV is the cause. So
Okay.
if you get HPV, you're not going to get cancer,
But you might.
but you might.
Okay.
Yeah.
And we as women have no way of knowing if a guy has it.
Correct.
Does he know he has it?
No.
No.
No. Yeah.
Because for my whole life, you use protection so you don't get STD, STDs,
Yeah.
the big ones.
Yeah.
Not HPV.
HPV's an STD. That's it.
Yes.
It's just that simple. Like
That's simple.
gonorrhea, chlamydia,
Yeah.
everything. It's the same thing. HPV's an STD. And so cervical cancer is a sexually transmitted disease cancer.
Ah,
Wow. Okay.
Yeah.
That's good information.
it is.
Wow.
It is.
Okay.
Yeah.
And we have a vaccine for it.
Yeah.
That we could eradicate this cancer from the human race
If
everybody had immunity.
right.
Right.
Yeah.
What's something you wish more women took seriously sooner when it comes to their bodies?
Wow, that's a really open-ended one. I think it would have to just be their general overall health and weight, because if we talk about the epidemic of obesity, and this is not a gynecologic thing, but this is just a thing that's just part of the Western world, part of our ready access to processed foods and bad diets. And we all are probably carrying around a little bit more weight than we should. But a whole lot of us are carrying around a lot more weight than we should. And the effect of that long term, into middle age, getting into pre-diabetes, high cholesterol, hypertension, needing to be on a number of different drugs. I mean, if folks really could understand that it's not about exercise, it's not about the gym. It's not about the gym. It's not about the clothes and the gym and the working out and the trainer and the routine and the discipline and the waking up. It all has to do with what you put in your mouth. And the longer I live is the more I realize that is really the mantra. And I struggle with it too. I'm struggling with it right now. I started to try, this is day 3. This is to tell you how I'm always trying things. I'm doing intermittent fasting. Yeah. And there's pretty good science around it. And I'm not saying that that's the be all and end all, but we're all struggling with, 20 to 50 to 60 pounds, most people, and I am too, and I love to eat, I work out and I try to be healthy and I try to exercise, but it's really not about that. It's really about what you put in your mouth. And if we really understood how bad our food supply is in terms of the number of processed things that we put into our bodies, we could really change who we are biochemically, So, somebody said it in one of my friend chats the other day, that if you're eating something that wasn't around, 2,000 years ago, you shouldn't be eating it.
Yeah.
It's
Or
just
something
that
that
simple.
can sit on a shelf for months and months and months and months.
Yeah.
And it's still
Because
fine.
our diets and our weight have such a profound effect on our overall health, even our cancer risk, that for me, I think that's the thing that really glares at me in the Western world, personally.
You see women delaying care. And if so, why do you think that happens?
Because they take care of everybody else. Yeah.
Right.
Because they take care
They're
of
always
everybody.
last on the list.
Yeah, they're
Yeah.
always last on the list. But I think that, newer generations, the millennials and the generations coming up. So I'm the first of the I'm Gen X.
Oh my.
Yeah.
Are you?
Are you Gen X?
I
I'm
don't
Gen
know.
X.
Oh,
I'm
geez.
81,
Yeah.
but I think I'm on the cusp of something.
Yeah. So I was so I'm Gen X, and but I think people are getting more into healthcare.
Yeah, I agree.
More into self-care.
Yeah.
And being more careful about, I think that
Yeah.
the mom who neglects herself hopefully is gonna be the paradigm that maybe we'll hopefully lose soon.
Yeah.
But I think that folks do really get really busy with life and careers,
I agree. Yeah.
and sometimes just forget the simple things that they can do to screen for diseases.
How do you think women can better advocate for themselves if they feel dismissed by their doctor?
Oh, dismissed by your doctor. Gosh, that's just a terrible thing.
It happens a lot.
It happens a lot. I know it does really happen a lot. And so I think that then you go for another opinion,
Yeah.
I think,
People shouldn't be afraid to do that.
no, in fact, I tell patients all the time, because I very frequently tell people things that they really, really don't want to hear.
Right.
Yeah.
And I say, if you don't like what I'm telling you, I understand why. And I would really suggest that you go and hear this, or ask these questions of another provider. And, it doesn't matter to me that you don't come back to me.
Yeah.
But if you end up hearing this again and again, then you got to think that maybe the block is in you,
Yeah.
But if you're being dismissed by your physician, you absolutely need to get another opinion. And, a really good doctor should not be affronted by that.
Agreed.
If
Yeah.
if a patient wants another opinion.
I agree.
I think that the era, I do think that this is happening to the era of paternalistic medicine, yes, doctor, whatever you say. I mean, it's been long gone in OBGYN because the specialty is a majority of women now. Men are the minority. So I trained with mostly women. I was one of the few men in my residency program, and in the world of OBGYN, the minority are men.
Right.
But I think with Google, which is now, how old is Google? 30 years old or something. Now with chat, with AI, with everything that patients can do, if you don't like what a doctor is telling you, go somewhere else. And what you have to be careful of is that you don't doctor shop for the answer that you're looking for.
Yes.
Yeah, you're right.
You don't doctor shop for the
Yeah.
answer that you're looking for. But if you end up with a second opinion and you've basically heard the same thing, then you got to kind of say, well, okay, so I got to really take this in.
Yeah.
Yeah.
Agreed.
Yeah. It's good advice. If you could change one thing about how women approach their health in midlife, what would it be? I guess we've maybe already talked about that. Anything different?
In midlife, I would say really and truly carve out time for yourself. Carve out time for yourself. Continue to make your health a priority. Share responsibilities. The thing in the modern age is that so many women are not just the primary caregivers and the mothers and the wives, but they have full on careers and doing great things in the world, and men don't get that. That requires us to step up and share. So if you have a spouse, what I would say to the men is that if you have a spouse that has a career that is as busy or busier than yours, then you really got to think of the relationship that you have, whether you have a family, kids, or parents, or whatever. But whatever you're doing, it really has to become a completely shared thing.
Yeah.
Because how can you expect your spouse, a wife who's at home, who, unless she is at home and you've made a family decision that somebody's a homemaker and somebody's a breadwinner, but if you're both out in the world, then you both have to be breadwinners and you both have to be homemakers.
Right.
Yeah.
And but yet it isn't really happening. It isn't really happening, because there's still a huge weight of responsibility for
Right.
everything that still falls on the woman,
Right.
which is just not commensurate with trying to also have a big career. So what happens is that, it's back to the thing that we've talked about at least twice before, but then the woman is like, I'll get to my pap smear.
Yeah.
I'll get to this funky lump that I feel in my breast. I'll get to it because I have them, I have him, I have the house, I have the dog, I have my sick parents, and I'm really trying to be a first-rate corporate lawyer
Yeah. Right.
or a first-rate accountant.
Yeah.
So what goes down the tubes?
Yeah.
Right.
That's last on the list for
Yeah.
sure.
Yeah.
All right. That's the last of my questions. Is there anything else you have?
No, I don't think so.
Not for this episode?
Not for this episode, but I do think that it would be great to get you back and talk about a lot more, because I think that there's so much more that we can talk about.
Yeah, we could really focus in on a couple of the things a little bit more.
Anatomy.
We could focus on anatomy. We could bring some charts. We could put some. We could put some slides up in your in your podcast. But yeah, there's tons to talk about. This was like a very general health preventative, epidemiologic kind of like overview discussion. But we could talk for hours on individual cancers.
Oh, or even just, the HPV and STDs and all of that kind of thing.
Yeah, it doesn't
too.
end when you're in midlife.
No. Well, we really appreciate this. If anyone wants to get a hold of you, like, do you always say go and see your gynecologist first and then you get referred, or can people just
So
contact
in Cayman, folks can book appointments with me directly.
Okay.
In the States, to see a gynecologic oncologist usually requires a referral.
Okay.
But, this is a smaller place and better access, and Health City really is trying to make subspecialists accessible. Sometimes I'll get a patient coming in for something that really is not what I do or not what I want to be doing, and I'll say, you really should see a general gynecologist. And, there's a whole group of amazing OBGYNs on this island.
Agreed.
Over 25 OBGYNs on an island for 80,000 people. So there's no shortage of, ages, genders, races, locations to fit what you're looking for. But I'm happy to see folks, and for people to get in touch with me, they can email me.
Okay.
Which is really simple. It's my first name dot last name at healthcity.ky. I'm
we'll put
always
that up
happy
as
to get an email from a patient. Or you can just call the clinic and get an appointment.
Right. I was just going to say as well, our podcast also reaches North America.
Oh, yeah.
So if anyone do you have to be within the Florida area to see you? Or
No, anybody can come from anywhere.
Anywhere.
Yeah, anyone can come from anywhere. I mean, gynecologic oncology is a pretty small specialty. There's not a lot of us in the specialty across the country. So, but we are in most states. And in most big cities, but someone can come and see a gynecologic oncologist anywhere.
Perfect.
Yeah.
Okay.
This was great. Thank you for this.
Thank you.
My pleasure.
Thanks for joining us on Breast Intentions. We hope you felt seen, supported, and maybe had a few laughs along the way. Don't forget to share, subscribe, rate, and review us. Your support keeps the conversation alive. Follow us on social media for more insights, behind-the-scenes fun, and updates on future episodes. Got a topic you want us to dive into? We'd love to hear from you. Remember, life's too short for bad bras, toxic relationships, and kale you don't actually like. So until next time, stay bold, and keep your breast intentions exactly where they belong, front and center. Now go crush midlife, or at least today's to-do list. Cheers!